Hi, this is Elliot Fisherman, and I'm live on YouTube. Hope everyone is doing well. Today is the 22nd of December, 22, Thursday. It's in Baltimore. It's raining like crazy. Temperatures in the 40s. Those of you in the U.S. know that there's a gigantic storm coming across. Temperatures are supposed to drop in Baltimore from 50 to 8 tomorrow overnight, and a lot of the country is really going to have issues with heavy heavy snow. And I guess if you want to know why Christmas, this is going to be a year. People are saying this is the worst weather on Christmas in 40 years. And worse is always relative, but we'll see what happens. Those of you who need to travel, hopefully your flights will not be canceled. I know they already started canceling flights today, so it's kind of going to be a painful process. Anyway, um, I'll take this opportunity, though this is not the last time we'll speak, to wish everybody a happy and healthy holiday. Whether you're in the middle of Hanukkah, Hanukkah began on Sunday night, so tonight's the fifth night, or if you're Christmas, you're 3 days away or 2 days away from Christmas Eve. So that's exciting for everybody, and wish everybody a great holiday season, and that leads into a happy and healthy new year. So that should be great. Now, this talk is on large adrenal masses. Okay, I gave a talk on that at a course a couple weeks ago, very popular, and it is a challenge. I know we always talk about adrenal lesions, benign, malignant, but what you see with larger lesions, there was an article from Mayo Clinic, only 20% of large adrenal lesions, large being defined as 4cm, are actually malignant. However, it's hard to look at large masses at times and just say, it's nothing, leave it alone, don't worry about it. Now, large masses can be obviously benign. Think a adrenal cyst. Think a classic adrenal myelolipoma. Over 5 cm, most people will say, some people say 7, you're resected because of the propensity to bleed, but it's benign if you recognize it. What else can be benign? We could talk about a range of things, but that's the problem. It could be on the benign side a hematoma. It could be an adenoma. I've seen adenomas 10, 12 centimeters. It could be a pheochromocytoma. It could be adrenal cortical carcinoma. It could be metastasis. It could be lymphoma, particularly lymphoma is bilateral. And did I mention pheo? I'm sure I did. What you try then to do is try to figure out what you're dealing with. Is the patient syndromic? If the patient's cushingoid, you better be thinking about a primary ACC. If they're hypertensive, then you're thinking about a pheochromocytoma. What's their lab values? Are the metanephrine levels up? Or are they down? Or are they normal? What's going on? And so large masses, you want to do adrenal profiles, make sure you're not missing any functioning tumors or hyperfunctioning tumors. It's a better way of describing it. The challenge is when you have a classic adrenal cortical carcinoma, it's 10, 12, 15 centimeters, vascular, necrotic, neovascularity. It looks really bad. That's easy. But there's other ones that are homogeneous, 6 cm. Pheochromocytomas, they're typically hypervascular, but occasionally you get fooled with big pheos that they're very cystic. So a large cystic lesion could be necrotic met, necrotic ACC, or pheochromocytoma. Again, history will be important. Pheos are more likely bilateral, mets are more likely bilateral, lymphoma can be bilateral, metastatic melanoma gives big mets, hepatoma gives big mets, so you can have bilateral adrenal masses. Now, obviously, metastasis, that's usually the clinical history. Common things are common when they're vascular, it's renal, HCC, melanoma, lung cancer. Okay, great. But what else do we need to talk about? ACCs, adrenal cortical carcinoma, are large, but we've seen some of them 1 to 2 centimeters, but typically they're large and hypervascular, they're necrotic. They may have periadrenal spread, they may not. Pheochromocytomas are vascular, enhancing over 120. Again, you can have cystic pheos. When you have a cystic lesion, you're dealing with thinking pheo, thinking ACC, even thinking potentially metastasis. So it is kind of a challenge. Pheochromocytoma, as I mentioned, Lab values are helpful. The bigger ones can be necrotic, so a lot of overlap there. Um, I've also had a number of cases of patients without hematomas. Yes, we think of hematomas bleeding into an AML. That's easy to see fat. Bleeding into an ACC, bleeding into a MET, bleeding from a pheo. But we also see bleeding into adenomas. And maybe it's a big mass, fairly homogeneous or mottled in appearance, and you have to take it out because there's no way you can look at it and say, oh, there's an adenoma that bled. In fact, bleeding is easy when you know about Coumadin or trauma, and usually they're smaller and they're ovoid. But when things get really large and the presentation is hematoma, or maybe you're thinking hematoma, but you really don't have a reason for it to bleed, it's a challenge. Maybe you have an underlying tumor. Lung cancer is a good example. But maybe you have no tumor anywhere. Maybe it's an occult tumor. Maybe it's a pheo that bled. So bleeding is a good thing, perhaps, as a sign for thinking, but it's not perfect, and you will be wrong because you will be resecting things that are, an old hematoma. But there's no way from CT you can make that call. Yes, this lesion is not very vascular, if it's vascular at all. Yes, it's well defined, but it's hard to call that as a leave alone lesion because ACCs can look like that. Tomorrow I have conferences. Every week there's 2 or 3 cases, or at least that I'm not sure about, that I could say it's benign, maybe, but I can't say it's not malignant. And those will be resected, not biopsied, they'll be resected. If I think it's benign, it's surely going to be resected laparoscopically. If I'm sure it's malignant, then it's going to be resected with an open procedure. Laparoscopy, like for many applications, is so much better. Shorter surgery, a day in the hospital, rapid recovery, classic adrenalectomy, a week in the hospital, and a long, slow recovery. But if you have a suspicious for malignancy, you have to do an open procedure. You got to get all the nodes. You got to make sure there's no rupture of the capsule. That's the only way for those patients to survive. If you take out a big adrenal lesion and it ruptures, and it seeds, that's the end of the story. There's not much you can do. Mitotane is not going to help you in that regard. So you need a logical approach. Adrenal lymphoma, large masses, usually homogeneous, soft tissue density, often triangular in shape, usually bilateral, and can be very large. So if you see other disease like spleen or liver or nodes, that makes the diagnosis easier. We don't see that many cases of primary adrenal lymphoma, but often I think I can recognize them or at least suggest the possibility of that diagnosis. So that's things we can do, and we can be very helpful in making sure, again, that the right things are done. I mentioned to you that we don't do biopsies. There's maybe 2 times we will. If I think something's a lymphoma and I'm really convinced, they'll then biopsy it. If a patient has let's say a lung cancer, has an adrenal lesion, and it would affect what therapy they're going to get, what protocol they might go on, then they'll biopsy it. But they're not going to biopsy it to confirm that it's simply a MET unless there was a really strong reason that affects the patient's course for doing that. So things that we will be confused, and I'll speak tomorrow when I do the cases. Am I missing a hematoma? Is now homogeneous, minimal enhancement, or no enhancement? Am I missing a pheo? Not every pheo is over 120. That's a possibility. But these are cystic. The pheos that have a challenge with are often cystic. Most pheos are going to enhance above 120. Remember, we don't look at washout in pheos because all pheos will wash out more than 60%, and you can be fooled. Those are the main things I'm going to think about. Now, the reason I'm not going to do more than that is there's a lecture on CTisus. Our newest app is coming out, but the lecture is online already, CT of the large adrenal mass. Look at it there. I think if you do that, you're going to find that I tried to represent the challenges very well. I have a feeling that I was a couple of years ago probably more comfortable in being able to say I could always tell what a lesion is. Now I could almost always, but I could say this is malignant, this is benign, this I don't know what it is, and maybe I'll favor one over the other. So the adrenal challenge is real. Again, a logical approach, things to think about, what to do becomes very important. Work with your endocrinologist, work with your surgeons, and most importantly, work for your patients. And with that, from YouTube headquarters, I am saying to you, have a great day. Bye, everybody.